Welcome to MD310 Medical Care Provider. In this session, we'll discuss pain control. By the end of this session, you'll be able to define pain, identify common shipboard causes of pain, define the pain relief ladder, and list at least 5 progressive steps that can be taken to address any painful condition. Now, pain can be a very difficult sensation to characterize and explain because it's an individual's perception of noxious stimuli. You can't measure somebody's pain response. There's not a serum blood level of pain. You only have to listen to the patient and hear what they say. And there's lots of things that go into people's perception of pain, both physical things that cause the firing of nerves that are our pain receptor nerves, and also psychological factors and situational factors. And as you can see from this picture of the brain, there's lots of different parts of the brain that process painful signals. And so all those things, each of those areas of the brain are responsible for different types of thinking and processing, and so they affect our perception of pain many different ways. And it really varies from person to person. And it may or may not be associated with the injury itself. Any physical findings, for example, someone with back pain, often it's hard to find anything, and any secondary gain, that is not having to work, getting disability, or simply getting pain medications. So think about your working environment, Shipboard, and you can think of lots of different ways people can hurt themselves. Back injuries are very common from doing quite a bit of physical labor and from very awkward body mechanics and positions. People can very easily sprain ankles or strain muscles or even break bones. Cuts and lacerations and burns can be very painful, as can brush burns, abrasions, if they're large enough and in the right area. Head injuries, and even a multi-trauma patient, someone who's severely injured, may be awake and alert enough that they have pain control issues. So how should you approach pain? Well, you focus on treating acute pain. You're not going to manage people's chronic pain. It's just not going to happen in your environment. And everything you do has to be in the context of choosing the safest effective medication. Because pain control, the medications potentially have a lot of very bad side effects. And those can be harmful, even kill people. So you need to make sure that you choose a medication that's effective, because otherwise there's no point in trying to control the pain, but one that's safe while it's effective. So you want to improve patient comfort, you want to protect injured areas, and you want to improve their functionality. For many people, being able to control their pain means they're going to be able to go back to work rather than being out of work or having to be evacuated. And so we use this concept of a pain relief ladder. And you have these progressive interventions. They're increasingly intensive, which means they're potentially stronger, but also usually less safe. And what you use depends on the circumstance and the patient condition. And you do these things sequentially typically, although there's nothing that says you have to. If you're viewing an injury that's clearly very painful, the patient is clearly in quite a bit of pain, you don't have to start with the least intensive intervention. You may get back to that eventually, but you start with the appropriate level. Just make sure that you're making the safest choice possible. So oftentimes we want to choose non-pharmacologic, non-medicine-based treatments. And so for an injured extremity, immobilization with splints or wraps can often take care of most of the pain. Ice can be just as effective as a non-steroidal anti-inflammatory, and sometimes just as effective as a narcotic, depending on the type of injury, for a musculoskeletal injury like a big bruise or even a sprain. You want to elevate the injured part, and you want to let the patient rest it, but not in the sense of not doing anything with it. The old mantra of RICE, rest, ice, compression, elevation, is really fallen out of favor, and it's mostly because of the rest issue. What we found is that if we completely rest, don't use it all, an injured joint, and this is something that's not broken, or any other soft tissue injury, we actually prolong healing. It takes longer to heal the more you rest it. So the principle now is use until you have discomfort, and then rest until the discomfort goes away, particularly with muscle strains. And over time, your functionality will improve, and you'll be able to go longer and longer without having to rest because of pain. But for the immediate injury period, ice, elevation, and since it's always hurting, it's going to be fairly continuous rest in the first 24 hours of the injured soft tissue. That's incredibly effective. So when we think about what we actually do to treat patients, we think about our pain control ladder, and we start at the bottom with our non-pharmacologic interventions, which are the least intense and really, frankly, the safest. If those are effective, great. If not, we climb a rung to the non-steroidal anti-inflammatory drugs, the NSAIDs, and we're talking about things like ibuprofen, diclofenac, and aspirin. You can also use acetaminophen, Tylenol, or paracetamol. These are highly effective medications for mild to moderate pain. The non-steroidal anti-inflammatories don't actually have an anti-inflammatory effect until you've been on them for a few days on a standing basis. But even so, they're very effective in just blocking the pain receptors. For some people, this is all they need. In fact, some people actually get a fair amount of sedation from these medications. But for most people, they can take these for mild to moderate pain, be fully functional, and still be comfortable. If you find that those aren't effective, then you think about the non-opioid opioids like tramadol. Well, what's a non-opioid opioid? Well, tramadol was marketed as being a highly effective pain medication that was not a narcotic and therefore didn't carry the risks of addiction and abuse. Turns out that's not true. People can become addicted to it. They can abuse it, maybe at slightly lower rates than the opioids, but still there's a fair amount of addiction potential. Nonetheless, for some people it's a very effective pain medication. Muscle relaxants are also very effective, and muscle relaxants work in two ways. They do relax muscles that are in spasm. So if you've got an injured muscle that's in spasm or an irritated muscle that's in spasm, it will relax it and make it more comfortable. Doesn't do much for a strain where there's a tear in terms of helping the healing, but it's very effective in terms of reducing the discomfort from the spasm. The other thing that they tend to do is they tend to be sedating, and so they help people get a good night's sleep. And that actually contributes probably more than anything else to their healing. So these muscle relaxants, what I typically tend to do is start with my non-pharmacologic interventions. Then I use a non-steroidal anti-inflammatory or acetaminophen during the day. They're not sedating. They have very low addiction or abuse potential, and most people can keep functioning. And then I give people a muscle relaxant to take at night to help them kind of get to sleep and get a good night's sleep. And again, some people can take the muscle relaxants during the day and be fairly functional. Now, if you have someone with severe pain or you've gone through the pain control ladder and haven't been able to control it up to this point, you can think about your opioids, buprenorphine or morphine. Morphine is one most people are more familiar with. It's an injectable pain medication, IV, IM. There are oral forms, but you typically wouldn't have them shipboard. And those are very nice pain control medications because they've been around for a long time. They're very predictable in how they work, and they are very effective. The problem is they have high abuse potential, and they can cause very serious side effects. Low blood pressure, they can make people stop breathing, and people have died from overdoses of medical opioids during their treatment. And so it's very, very important that if you're going to use these, you're monitoring your patient carefully, but they will be very effective in managing the pain. Please complete the associated knowledge review, and if you have any questions, please contact your professor or instructor. Thank you very much.